Welcome back to Rungta IAS Academy aspirants. Today, we're bringing you an explainer that is absolutely crucial for your General Studies Paper 2 mains, specifically focusing on the health sector. We're breaking down the structural deficits in India's health system. Recently, Minister of State for Health Anupriya Patel shared some really eye-opening data in Parliament regarding medical education. We need to analyze this structurally to really grasp the gap between policy and reality, so let's get right into it. Right, and this data sets up a massive paradox, something you literally need to highlight in your mains answers. On paper, it looks incredible. We're seeing a huge government push, with 43 new medical colleges and thousands of new MBBS and PG seats approved just for the 2025-26 academic year. But here's the reality check. Out of those 43 colleges, 27 are in the private sector. They are charging high capitation fees, and they have absolutely zero obligation to post their trainees in government service. So the big question is, does simply building more colleges actually solve our world doctor shortage? Well, the short answer is a resounding no. And to back that up, here is a shocking number you definitely want to quote in your exams. 79.9%. That is the glaring specialist vacancy rate in our rural community health centers, or CHCs, across India. It's a hard, undeniable data point, and it completely exposes this massive gap between expanding medical education and actually delivering public health services on the ground.
Exactly. If you look at the Health Dynamics of India 2022-23 report, it breaks the shortfall down perfectly. We require practically 22,000 specialists in these rural CHCs, but we only have about 4,400 available. That's a massive shortfall of around 17,500 specialists. And you know what's really alarming here? This shortage has basically been stagnant since 2014, even though we've created over 72,000 new postgraduate medical seats in that exact same time frame.
Yeah, to really grasp how serious this is, let's quickly recall what a community health center is actually supposed to be. By the textbook, a CHC is the first referral unit for a population of about 1.6 to 2 lakh. It's mandated to have 30 beds and 5 core specialists: a physician, a surgeon, an obstetrician, a pediatrician, and an anesthesist. But the reality on the ground? States keep building these structures to utilize available central funds, sure, but without those specialists, they effectively function merely as primary health centers. And the fallout from this is severe. Out of roughly 5,500 CHCs across the whole country, only 882 can be fully operationalized. Think about that for a second. If you do the math across our 785 districts, we effectively only have about 1 functional CHC per district, and the feasible target is 7. So the physical infrastructure is sitting right there, but the actual healthcare services remain completely crippled. So as an administrator, you have to ask, why is this happening? Why do newly graduated doctors avoid these rural CHCs? Aspirants, you can list these exact points straight into your mains paper. Newly graduated specialists face huge roadblocks, a severe lack of basic medical equipment, no decent staff quarters to live in, a total absence of quality schools for their children, and completely inadequate peer medical support. It's not just that they refuse to go, it's that the basic socioeconomic ecosystem completely fails to support them when they do. Right, and this traces back to a fundamentally flawed budgetary focus. Our central health budget prioritizes capital expenditure, meaning constructing the actual buildings, over operational outcomes. We're building the physical shells of hospitals, which, let's be honest, often serves to gain populist political mileage. But we aren't matching those allocations for the doctors, the drugs, the ambulance services, or the diagnostics needed to actually run them. All of that burden is just left to be managed by already stretched state budgets. Okay, so how do we fix it? What is your way forward for the exam conclusion? Step 1, we really need to classify all PHCs and CHCs into normal, difficult, and most difficult areas, very similar to the successful Chhattisgarh Rural Medical Corps scheme, and provide special incentives based on that. Step 2, we must legally link government-sponsored PG seats directly to these existing rural vacancies. And finally, Step 3, enforce strict deployment rules. Building on those policy prescriptions, we should definitely prioritize candidates willing to commit to a 10-year service bond for those difficult area CHCs. But here's the real game changer. We must strictly enforce an all-or-none principle. You either post all 5 required specialists to a CHC together as a team, or you post none at all. Sending them in piecemeal just dilutes the service. Having a full, complete team improves the hospital's image, properly balances the workload, and most importantly, it actually serves the poor and marginalized. Which brings us to the end of today's explainer. Now, aspirants, put yourself in the hot seat. Imagine you are sitting in your UPSC personality test, and the mock interview board asks you this exact question. How do you justify building new CHCs when existing ones function merely as primary health centers due to an 80% specialist vacancy? Think about the structural arguments, the hard data, and policy solutions like the Chhattisgarh model we just discussed. Keep analyzing, use these exact points to enrich your answers, and best of luck with your preparation. Make sure to subscribe to Rungta IAS Academy for more deep dives into your syllabus.